Good evening, everyone. I'm honored to be here. I'd like to introduce our first speaker for this evening, Dr. Nguyen Ni. She's the director for the Center for Obstetrics and Gynecology at the Tam An General Hospital at Ho Chi Minh City, Vietnam. She's the former deputy director of the To Do Hospital at Ho Chi Minh Vietnam. She's a member of the executive committee, the Vietnam Association of Surgery and Laparoscopic Surgery, Executive Committee, Ho Chi Minh City Society of Endocrinology and Reproduction, and Vice President of the Ho Chi Minh City Pelvic Floor Association. I'd like to call to the virtual floor Dr. Nguyen Ni, who will give a lecture on hysteroscopic myomectomy in infertility. Dr. Ni?
Thank you so much, Professor Mario Antona Habana. And good afternoon, Professor Li Chin. Today, I'm very happy to present here, and good afternoon for the international our colleague. Today my topic is hysteroscopic myomectomy in infertility, and I like to present the experience in Vietnam. You know, the uterine fracture can be the 2 to 3% on infertility women, but the intrauterine lesions are much more common, and this lesion can compromise spontaneous fertility as well as reduce the pregnancy rate in ART. A published study suggests the increase of pregnancy rate after the hysteroscopic removal of the endometrial polyp and submucous myoma or uterine septum, etc., which can be found in 10 to 15% of the women seeking treatment for the subfertility. And fibroid, usually the benign tumor, are symptomatic, but having been associated with a number of clinical features, for example, abnormal uterine bleeding, especially in the heavy menstrual bleeding, or the infertility in the recurrent pregnancy loss, and the complaint related to the impact of the enlarged uterus on HSC structure in the pelvis. You know, here prevalence of the fibroid in some country. For example, the United Kingdom is near the 5%, but Italy, the double, near the 10%. And for the problem of the infertility, the evaluation of the uterine cavity is a basic step in the female infertility workup, hysteroscopic and the transvaginal sonography. The both are the most commonly used for this purpose, and the hysteroscopy is considered the gold standard for diagnosis of the uterine intrauterine lesion. And some specialists are thinking the benefit of the systematically of the hysteroscopy in the initial assessment of infertility, but remains unclear. Systematic hysteroscopy before IVF now widely accepted practice, which is supposed to improve pregnancy rate, but still lack scientific evidence. And in this case, the repeat implantation failed in the IVF cycle. Uterine cavity should be evaluated by hysteroscopy, and this practice has been demonstrated to improve pregnancy rate. Sometimes you can see that we can find some picture here, fibroid intracavitary or the hyperplasia. For the infertility mechanism whereby submucous myoma impact fertility are just now unclear. But some evidence maybe the submucous myoma may contribute inhibit the receptivity of the endometrium to implantation, or and the reduction in the level of the endometrial HOSA 10 or 11 expression can contribute to inhibit the receptivity. And the both of the myoma and remotely in the endometrium overlying normal myometrium. Review the literature, a systematic review of the myoma and fertility. Please 2029, it is agreed that submucous myoma lower fertility rate and they remove or enhance the rate of conception and live birth. An Italian study, 1999, of the 108 women that use the ESG classification system, they see the fertility rate at the mean of the 41 months after the procedure were the 49%, 36%, and the 33% in the type of 1, 0, 1, 2 myoma, respectively. You know, we have some evidence for the submucous myoma and the infertility can explain the mechanism for the infertility. And recently published RCT, the 2010, compare TCRM, transcervical resectoscopic myomectomy, with no treatment in the more than the 200 women with the primary infertility who were demonstrated to have a submucous myoma, and the women were randomized to the TCRM or the diagnostic hysteroscopy with the biopsy only. And during the follow-up periods, we can see that more than the 60% of the treated group conceive as compared with the 28% of the untreated group. Fertility rate increased after TCRM for the type 1 and the type 0, but no significant difference were noted between the group for type 2. Here we have many classification for the leiomyoma. For figure the 2018, you know, we have a leiomyoma, the subclassification system with the type 0, 1, 2, and now type 3 is a submucosa fibroid. Classification of submucosal myoma follow the ESGA. Classification for the three groups, the type 0, type 1, and type 2. For the type 0, you can see here entirely within the endometrial cavity. And type 1, the less than the 50% myometrial extension. That means the less than the 19-degree angle of the myoma surface to the uterine wall. And the last, the type 2, more than or equal the 50% myometrium extension. That means the more than the 19-degree angle of the myoma surface to the uterine and wall. And we have more the classification of the myoma step W the system. For the step W the classification, we have a side topography, extension, base, penetration, and lateral wall, etc. So for the hysteroscopic the myomectomy, we think that to choose in our study classification or the ESG, it seems very easy. Here you can see in the human reproduction update 2016 about the uterine fibroid management from the present to the future, management of the type 0 myoma. That's been the hysteroscopic myomectomy is the most appropriate approach. And for the type 1 myoma, depending on the myoma size, present of the anatomy and the surgeon skill, etc. With the myoma less than the 3 centimeter, we can directly the hysteroscopic the myomectomy. But more than the 3 centimeter, consider treatment, medical treatment before the surgery. And AHGL practice report, practice guideline for the diagnostics and the management of submucous leiomyoma a proposal for the submucous myoma treatment by the hysteroscopic surgery. You can see here resectoscope and instrument for the distension medium flow to the resectoscope. We have many instruments, maybe the unipolar mode and the bipolar mode. Traditional resectoscope are designed more for the monopolar electrode and require the non-conductive distension media to allow the completion of the electron circuit, such as glycocone or sorbitol. In contrast, with the bipolar electrode or laser fiber, we can use conductor media such as normal saline. And the technique hysteroscopic myomectomy follow the AHL. You can see here that with the myoma, the intracavitaire, we can just separate the half and we cut above to fundus to the ostium of the cervix. And during the hysteroscopy, the AHL practice report emphasized the fluid monitoring guideline for the hysteroscopic distending media because of many complications due to the distending media isotonic. You know, the hysteroscopy are performed using an endoscope with the intrauterine distension, maybe the carbonic gas or the fluid distending media. Because of the risk of the embolism, carbonic should be used exclusively for the diagnostic purpose, whereas fluid media can be used for the both diagnostic and operative procedure. You can see here the mechanism of the action of the fluid balance component. And the fluid media can be low or high viscosity or low or high molecular weight, and can be either electrically conductive or non-conductive. Understanding the physical property and the potential risk associated, we can prevent the distending the media is critical for the safe performance of the hysteroscopy, the surgery. And selection for distending media now, compared with the hypotonic and the electrolyte free media, isotonic solutions are associated with a reduced risk of the hyponatremia. Wherever possible, isotonic media should be used when performing operative hysteroscopy. Electrolyte-contained media are incompatible with the monopolar hysteroscopy, but electrolyte-free isotonic solutions are available. Mannitol, glycine, sorbitol, etc. And summaries of the hysteroscopic surgery follow the AHL, damage of the cut to the cervix, perforation of the uterus, which may lead to more procedure, inability to completely remove the fibroid within once, maybe it's different for the with one surgery. Too much fluid used during the procedure, maybe circulation overloaded, and development of the synergy some weak or month after the procedure. And in Vietnam, what I do, you know, the subserous and intramural myoma before we know with the infertility in controversial, but the submucosal myoma, which are reported in the 5 to 18% of patients as a cause for the infertility. So it depends on the location. Myoma can be treated exclusively using surgical procedure, and they may be accessible by hysteroscopy. And many retrospective study published have demonstrated successfully reproductive outcome after hysteroscopy removal of the polyp of the submucosal myoma in the infertility women. And MR of study, our retrospective study were to evaluate the subsequent fertility and outcome of the pregnant after hysteroscopy myomectomy according to the characteristics of the submucous myoma, type of submucous myoma, number and size of myoma, and with the include the criteria or the infertility with some with the micro mucous myoma confirmed by ultrasound, and duration of the infertility more than or equal to 12 months, and only those patients who had a follow-up of at least 12 months from the day of surgery were included. And we have two exclusion criteria: azoospermia and age of patient more than the 40 years old. And the study was conducted from the September 2017 to December 2020. On the patient with infertility were checking all the associated cause of infertility. And for example, semen analysis, bilan of Bono, and follicular study, etc. And on detail of the subsequent fertility were obtained from hospital record or the telephone direct or the direct information from the patient. And we use classification follow the ESGR type 1, type 1, and type 0, type 2 for the the submucous myoma. And we have 36 patients, and duration of infertility from the 12 to 110 months, and the mean duration of infertility the 43 months, and the 21 primary infertility. That means the near the 60%, and the second and the 15 secondary near the 42%. A total the 36 infertility patient has undergone hysteroscopic myomectomy who were subfertile and fulfill on criteria were included. And we have 3 cases due to the size of myoma, the were 5 to 6 centimeter, and the severe anemia with the hemoglobin less than the 6 gram percent. We give a GnRH analog during the treatment, and then we check and by ultrasound the size of myoma the less than 5 centimeter, that we give an indication for the surgery. On hysterectomy, on the hysteroscopy, myomectomy were performed under general anesthesia or the spinal anesthesia, and on complication was recorded for in the document, and surgical technique using resectoscope with the bipolar wide loop by the gastroc with extension medium is a normal saline. Intrauterine pressure was controlled by Habu Angdomat, and the recent carrier individual controlled from the fundus to international. And we have 3 complications in our surgery: 1 intraoperative bleeding, 1 blood transfusion, and 1 tear of cervical, and no complication for intravasation with the distension media. We can see here. The hysteroscopic, the myomectomy, we use the myotip type 0. Yes, it's a step by step. We cut and we remove the myoma. Here you can see here that we have 3 myoma. And some reason age the mean the 32 years old, and duration of infertility the 42 months, and duration of the intervention the mean the 41 minutes, and the hospital stay mean the 46 hours, and the duration of the follow-up the 19 months. And we have some patient heavy menstrual bleeding, and after hysteroscopic myomectomy, we have 7 patients undergo the IVF, ICSI, and IUI. And pregnancy outcome according to the type of myoma. The type 0, we have 58%, the number of the patient with the pregnancy after surgery. For the type 1, we have 58%. Type 1, we had 40%. And for type 2, we don't have pregnancy, no case. A total, we have 47% the patient with the pregnancy after surgery. And the pregnancy outcome follow the size and the number of myoma. We can see here size less than or equal to 3 centimeter. The number of the patient with the pregnancy after surgery, that's mean the 52%. And for the size more than the 3 centimeter, we have less than the patient with the pregnancy, 45%. And the number of the myoma, less than the 2, we have 52%. And the number more than the 2 myoma, we have 29%. In the 36 cases, more than 3 centimeter, we have 8 cases more than the 3 to 4 centimeter, and 3 cases 4 to less than the centimeter. And the comparison, reporting on the reproductive outcome after hysteroscopic myomectomy with the other order. Yeah, you can see here that the series of the UFAD number patient more than the 130. The ratio, the percent of the patient with the pregnancy, near the 60%. And golden bear, the 40%, and Vasalini, the near the 30, and Bagda, the near the 32, 34, and the Fernandez, the 27. And in our study, in the 47%, 47%, we follow up the maybe the longer than the other order. So the 30 month. From September 2017 to the September 2020, pregnancy rate after hysteroscopic myomectomy infertility in our study was the 47%. And outcome of the be pregnant according to the type of the myoma, the best reason are the type 0, near the 60%, and then the type 1, 40%. And the number of the myoma, only one myoma, we can you can see here the 52%, and with the more than the 2 myoma, only the 29%. And no severe complication. Shortly during of the intervention stay of hospital, the pregnancy rate after the procedure, as reported by various studies, had been described. We need more the big sample size as well as more research. And conclusion, hysteroscopy is considered the gold standard for the diagnostic and treatment of intrauterine lesion. And submucous myoma can compromise spontaneous fertility as well as reduce the pregnancy rate in assisted reproduction 40 to 50%. And it depends on the location. The submucosal myoma can be treated by hysteroscopy. And wherever possible, isotonic media should be used when performing operative hysteroscopy. That's mean the bipolar the electrode. And many retrospective studies published have demonstrated that successfully reproductive outcome after hysteroscopy, removal of the submucosal myoma in infertile women. And in our study, the pregnancy rate was 47%. And surgeon skill and understanding the potent risk associated with the use of the various distending medium is critical for the safe performance of the hysteroscopy myomectomy. Thank you so much for your attention with my topic.
Okay. Thank you, Dr. Need, for a fantastic lecture and a very interesting study. I'd like to say hi again to our 197 participants and attendees who are listening to you right now. And there are several questions already in the Q&A box. I'd like to start off. I think we're given 10 minutes for this, and there are quite a number of questions. So for the first question, do you use anti-adhesives after doing myomectomy? And if you do, which intrauterine anti-adhesive do you prefer? Dr. Ni?
Sorry, to repeat again, please.
Yeah, okay. The question is, do you use anti-adhesives after doing myomectomy? If you do, which intrauterine anti-adhesive do you prefer? Do you want me to repeat it, Dr. Ni?
Yes, repeat or the taper, please.
Okay. So
yes.
Yes. Do you use anti-adhesives after doing myomectomy?
Yes.
And if you do intrauterine anti-adhesive, which do you prefer? Yes. Go ahead, Dr. Ni.
Yes. Thank you. Some case, if the big size of the myomectomy, you can see that we make a damage of the endometrium. So the endometrium that is remove many square. So I use the hormonal estrogen for the push endometrium no need push in the intrauterine. We give the hormonal, the estrogen and progesterone in the one or the two cycle. And the myomectomy, laparoscopic myomectomy, and sometimes we use the band for the cover in the surface of the uterus for the anti-adhesion. But in the Nhi-Hysteroscopic, the myomectomy, we use the hormonal and not the anti-adhesion.
Okay. Thank you for that, Dr. Ni. The next question is, if you have patients who have stenotic cervix on the day of surgery, what do you do? Do you do cervical priming prior to?
The cervix.
The cervix.
Yes, ripening cervix, we use a misoprostol.
Okay.
Yes, misoprostol. And then the dilatation, because the misoprostol, some hours before the hysterectomy is very easy and comfortable.
If despite misoprostol, the cervix is still stenotic,
yes.
What do you do? You just do mechanical dilatation of the cervix?
Yes. We use the misoprostol, and then the dilatation and the number six, and for the diagnostic, and then the number 8 or number 9 dilatation.
For the
yes.
Yeah. For the operative.
Yes, operative.
There's another question, and I'll skip some because we might not have time for all, but there's a question on your study, and it said that in the 3 patients who were given GnRH preoperatively, were you able to achieve adequate decrease in size and avoid a 2-stage myomectomy?
Yes. For the laparoscopic, the myomectomy, we don't use it. We don't use it because no need, because you know the myoma, the subcellular or the intramural is very small, so that we can do not musculature or the tear or the fix. But subcellular myoma. We can use it because you know in the case of the severe anemia, I don't think I think that no need to plus the transfusion. We use Genrash for the make amenorrhea, for the stopping bleeding, and then the endometrium is very thin. It's comfortable for the operating, and then the myoma maybe the reduce, but not much more. But reduce the endometrium is a thing, and the reduce the size not more, but the follow up for the hysteroscopic, the myomectomy. We can use in the subserous myoma, but we don't use in the laparoscopic, the myomectomy.
Okay. There's a question also, because you have very good pregnancy rates in your study, and there's a question is how soon after myomectomy do you perform the IVF?
Yeah. For the if type 1 or type 0, we after the 1 or 2 cycle, we can transfer the patient to the IVF center. No need more.
Okay. Do you suppress after you do your hysteroscopic myomectomy? Do you suppress the patients prior to doing IVF?
Yes, because the patient have some problem. For example, the problem of the semen or problem the etc. So the transfer directly the IVF center. And if they don't have education for the IVF, we can follow.
Okay, so there's still a lot of questions, Dr. Nguyen. I hope you can try to answer them online, but I'm getting a signal that I have to stop the Q&A. I just want to wrap up your study for the audience that you had very good outcomes, as high as 47% pregnancy rates. And this is seen especially if the myoma is less than 3 cm, if they're type O, and there's only one myoma that's present. Again, thank you so much for that very interesting lecture, Dr. Nhi. I'm turning over to Dr. Yen. Okay, thank you.
Thank you so much. Thank you so much.